Hi, welcome back to another online series of periodontics. And today we are going to be discussing periodontal dressings. As you all are aware, periodontal dressings are usually provided post periodontal surgery. So today we are going to look into the various details of periodontal surgery, periodontal dressings. What are the various types of periodontal dressings available to us? What are the ideal requirement of a periodontal dressing? How to use it? How to apply it? How to take it off? What are the contraindications? Everything in this today's presentation. So stay with us. Stay with me. Let me share my presentation screen. Right. I hope you all are able to see the screen now. Right. So periodontal dressings, as I've just told you, what all are going to be part of the content list for today. We are going to be looking at different types of dressing material. We are also going to see the substitutes for the dressing material, how you're going to place it, how you're going to retain, how you're going to remove the pack once it has been placed, what are its biological and physical properties. Is periodontal dressing for all? That means, is it supposed to be placed for every patient or we can skip for some patients? We're going to learn that today. So, starting with a brief introduction on periodontal dressings. So, basically, it is a surgical dressing which is used post-operatively to cover, uh, one second, to cover and protect the surface of the surgical wound which has been created after periodontal therapy. The sequelae of the surgery are commonly pain, inflammation, swelling, and bleeding. And therefore, many periodontists feel that after surgery, the area needs to be covered so that it is protected from any further injury. Injury due to food, food pressure, injury due to toothbrushing pressures, all that. So that is what the previous and all the periodontists majorly advocate. That is why they advocate the usage of periodontal dressings. Now, if you look at the history part, it was Ward in 1923 who discovered Wonder Pack. This is the first periodontal dressing to be discovered. Just consisted of zinc oxide eugenol mixed with alcohol, pine oil, asbestos fibers. After that, in 1942, Boxenham used zinc oxide eugenol mixture to perform chemical curettage, also called as chemosurgery, to treat necrotizing ulcerative gingivitis. Thereafter, in 1947, it was Bernier and Kaplan who said periodontal dressings or the ointments which is used in periodontal dressings are supposed to be used for wound protection and not for any sort of surgical procedures. 1962, Blanky used it to control post-op bleeding and also to splint the loose teeth. So therefore came in 1969 the Baer et al., the group of workers, the group of scientific workers who stated that the primary purpose of dressing is for patients' comfort, to protect the wound from any further injury during healing, and to hold the flap in its place, and not to splint the tooth structure, not for any sort of post-op bleeding control, because bleeding control is done by means of proper degranulation of the tissue and suturing, not the periodontal dressing. Its work is not to control bleeding. Its work is to only put the flap in place so that it is not moved when the patient is brushing or the patient is eating something. So it was Baer et al. In 1969 who actually stated the real role of periodontal dressing. Now, what are the uses of periodontal dressing? First, importantly, mechanical protection of the surgical wound. Second, it enhances the patient's comfort. Thirdly, it prevents post-op bleeding to prevent any sort of bleeding. Then maintenance of debris-free area so that no food gets accumulated there. Supporting of the mobile teeth during healing, not just to, okay, you need to be very careful about this. Baer said it is not supposed to be used for splinting of the teeth. That means you're not supposed to use periodontal dressings instead of fiber splints. Fiber splints work is to make sure the teeth are supported in place. but you're not supposed to use a dressing material to hold the tooth structure. But yes, during the healing process, some sort of tooth movement is anticipated. So to hold that, we can use a dressing, but not for a very long duration of the time, unlike splints, which are placed for a little longer duration of time, minimum 3 months. Then the ideal requirement of a dressing, it should be soft, but still have enough plasticity and flexibility. It should set within a reasonable time. It should not take like hours to set. Like this patient cannot literally wait really long post surgery. It should have sufficient rigidity, obviously. Then surface must be smooth after setting. And there has to be some sort of bactericidal properties in the periodontal dressing, which is one of the most important factor of an ideal property amongst periodontal dressing. Should not interfere with the healing process. That is one thing. Dimensional stability should be there. It should not induce any sort of detrimental effect or allergic reactions. It must be acceptable in taste. It should not be distasteful because it's going to stay in the patient's mouth for at least a week. So it should not have any sort of problematic taste. It should be economical and easily available. And then last one, it should have a good shelf life, like 2 to 3 years, so that it can be used for a number of patients. What is the reason behind putting periodontal dressings? We have already come across that to protect the area, to enhance the patient's comfort, and so on and so forth. Now, there are different types of periodontal dressings which is available to us. One, those who contain zinc oxide and eugenol. Then there comes those which do not have, which have zinc oxide but without eugenol. And then third are those which do not have either of the two. So we're going to look at all the three types of periodontal dressings. Now, we are coming first to the eugenol dressings, the ones which had eugenol. We know that Wonderpack, A.W. Ward, 1923, the first periodontal dressing was introduced. It had powder and liquid. The powder had zinc oxide, powdered pine resin, tannic acid, and asbestos. The liquid had isopropyl alcohol, clove oil, pine resin, pine oil, and peanut oil. Also, Kirkland formula, which had zinc oxide, resin, zinc acetate, and eugenol and olive oil. So this was one example of the eugenol dressing. The few components were added to improve the properties, like addition of zinc acetate. They were mixed together on a waxed paper pad using a wooden tongue depressor or a spatula. The powder or a paste is gradually incorporated into the liquid until it reaches a dough-like consistency. You've seen how zinc oxide powder and eugenol are mixed in conservator, the same way the pack was prepared. The dressing may be used immediately or wrapped in aluminum foil and refrigerated for use for up to 1 week. The setting time of Ward's Wonder Pack under oral conditions was 24 minutes. It required approximate half an hour for it to set, which was shown to be less than its working time under room conditions because both heat and moisture accelerates the reaction of zinc oxide eugenol. So that means when the pack was placed inside the mouth, because of the heat and the moisture, its setting time was increased, and therefore it took almost half an hour for it to set, while its working time was less. Now, the role of eugenol. Eugenol has been used in gingivectomies, in chemosurgeries. We saw that in the history part. Weirach in 1957 said that eugenol has been used to prevent or retard bacterial growth based on their antiseptic properties. However, eugenol was found to irritate the oral mucosal tissues. It has also been found to induce some sort of allergic reactions, and it causes more damage than it does any sort of help. Furthermore, it presents difficulties in manipulation and has a rough surface for after setting. There has been histological evidence of greater tissue destruction with the usage of eugenol. Eugenol has also proven to be cytotoxic at higher concentrations and has an adverse effect on fibroblasts and osteoblasts-like cells. All these reasons led to the development of non-eugenol dressings post 1950s. So now these are the various examples of non-eugenol dressings: cross-pack, co-pack, septopack, peripack, etc. We're going to see that all these important ones one by one. Co-pack, this is the most widely used. You will see it in our department also. You will see it in most of the periodontal clinics. It's been widely used as intraoral dressing, manufactured by co-labs, hence it is co-pack. It has a base paste and a catalyst paste. Base paste has zinc oxide with added oils and gums. and lorothidol, which is a fungicide. Catalyst paste had coconut fatty acids thickened with colophony resin or rosin, and chlorothymol as an antibacterial agent. One second. Yes. Okay, this table depicts the entire base paste and the catalyst paste composition. You can look at this later on when the presentation is available online. Then you have crosspack. So crosspack was formerly the powder part of zinc oxide eugenol dressings which was in use in 1940s. It consisted of colophony powder, zinc oxide, tannic acid, bentonite, and powdered neomycin sulfate. It was used as a filler to Copac. Zinc oxide alone can be used instead of crosspack if desired, as told by Neal in 1975. Excuse me. Then Peripack. This is by Dentsply. It's a paste containing calcium sulfate, zinc oxide, polymethyl methacrylate, tetraethylene glycol, ascorbic acid, some flavors, and iron oxide pigment. So it had that brownish tinge, orangish brownish tinge to it. It reacts on exposure to air or moisture. The hardening of peripack begins as soon as it comes into contact with water, and it is complete in about 20 minutes. The application of dressing should not take more than 2 to 3 minutes, so it is very convenient to place. A correctly placed dressing will remain there for around 8 to 10 days, which is sufficient enough for us to cover up the surgical wound area. Peripack is indicated as a dressing following gingivectomies and papillectomies, also in deep curettage, in reattachment surgeries, etc. It can also be used in treatment of necrotic gingivitis and ulcers, protection of non-specific lesions, or sutured margins. Then after this, third was Septopack. It is by Septodont. This contains amyl acetate, dibutyl phthalate, butyl polymetacrylate, zinc oxide, and zinc sulfate. It is a self-hardening plastic paste, so you don't have to mix it with anything. It's a self-hardening paste. You take it out and it hardens very soon. The working time, as stated by the manufacturer, is 2 to 3 minutes, and the setting time is 30 minutes, somewhere just as same as the Wonder Pack. It can be combined as a neutral medium with some medicines. So all this Peripack and Septopack, they do not have any antibacterial agents, unlike Copac, which had chlorothymol, and fungicidal agent, that is lorothidol, right? So likewise, these Septopack and Peripack do not have any such medicinal component. So you need to add some medicinal component to it. So what we can do here is in Septopack, we can crush open a tetracycline capsule and then use it so that it has some sort of antibiotic in it for antibacterial actions. Then Periocare. This comes in 2 tubes. One contains a paste of metal oxide and vegetable oil, and the other contains a gel of rosin suspended in fatty acids. Equal amounts are dispensed on a glass, mixed and applied. The setting time for this product is 45 to 60 seconds, and the working time is 4 to 5 minutes. So it's a very good alternative to Copac. Then you have Periopatti. Periopatti is another non-eugenol dressing which has methyl parabens and propyl parabens and also benzocaine. Periogenics. Periogenics is a non-eugenol dressing manufactured by Oroscience. Contains perfluorodecalin, purified water, glycerin, hydrogenated phosphatidylcholine, cetearyl alcohol, polysorbate, and a lot of other ingredients, as you can see on the presentation slide. It has been said that this dressing accelerates healing of post-op surgical wounds, as stated by Mulliken in 1995. It was also observed that wounds treated with periogenics demonstrated an upregulation of vascular endothelial growth factors, collagens 1 and 3, and also matrix metalloproteinases levels. Periogenics allows for the exchange of oxygen and carbon dioxide into and out of the injured tissue. So this was found to be really very effective. The main advantages of non-eugenol dressings are minimal irritation of the mucous membrane, because eugenol used to irritate. That is what we found in studies. Pleasant odor, neutral taste, and ease of manipulation. Because we saw in certain studies where they noted that eugenol was having rough surface, so ease of manipulation was low. While in non-eugenol containing periodontal dressings, there was ease of manipulating it. Although they possess neither the analgesic or antibacterial properties of eugenol dressings, they are less irritating and forms a closely adapted adhesive barrier to saliva and oral bacteria. So except Copac, we could not see any other periodontal dressing, non-eugenol ones, having any sort of antibacterial properties because they did not have anything to support it. But still, we found that if we crush open certain antibiotic tablets and then mix the pack, we can still apply it onto the patient's surgical wound area and put the flap into place. Now, the dressings containing neither zinc oxide or the eugenol. This is the third category, the third group. This includes cyanoacrylate dressings, light cure dressings, collagen dressings, and mucoadhesive dressings. Cyanoacrylate. So, cyanoacrylate alkyls were obtained for the first time in 1949 by IIDS. In 1959, that is 10 years later, Hoover et al. Synthesized tissue adhesive materials and suggested their possible use as surgical adhesives. Only N-butyl cyanoacrylate was found to be biocompatible and therefore was suggested to be used in surgical procedures. Two of their examples are histoacryl and periacryl. You need to remember these names to quote when you're writing about cyanoacrylate dressings. As a dressing, it has been evaluated clinically and histologically, following procedures like gingivectomy, mucoperiosteal flaps, excisional biopsies. Rapid hemostasis has been seen in presence of moisture for these dressings, and it has found to be accelerating the initial healing process also. Then comes light cure dressings. This I have personally also used, and I feel they are really a good alternative to zinc non-eugenol containing dressing material like Copac. Light cure dressings, as you can see in the picture, which is supplied by Dentsply, is a novel concept for the protection of periodontal surgical sites. It is a single component, comes in syringe, which allows us to directly place it on the surgical site. It is cured in increments with a visible light curing unit, and it retains its elasticity on setting. It gives a tinted pink translucent color. So even you after application, you can still see the surgical site and the sutures a bit, but it covers the aspect very clearly and properly. Then after that, you have collagen dressings like cola plugs, cola tapes. These are all examples of collagen dressings. They are biological dressings that creates a physiologic interface between the wound and the environment, and it encourages healing. The advantages over other dressings include ease of application, non-immunogenic properties, hypoallergenic properties. Moreover, an inherent property of native collagen is the ability to promote hemostasis. So it does that also. Additionally, the structure of absorbable collagen provides a 3D matrix for strengthening the blood clot. These are the various available collagen dressings as you can see on the right side of the presentation screen. Cola coat, cola tape, and cola plug. Basically, cola tape is used for localized ridge defects, socket grafting, for repairing any Schneiderian membrane tears, that is sinus membrane tears. Cola coat is used in procedures like soft tissue recontouring, sinus graft containment, in GVR procedures. Then you have mucoadhesives. Some surgeons reported the use of mucoadhesives whenever mucosal coverage is required for a short period of time. It is an adhesive, non-sensitizing wound dressing, which was patented by Peter and Howard in 1982. And it is a multi-layered dressing. It's not a single layer. Contains gelatin, pectin, and sodium carboxymethyl cellulose. And the longevity of the dressing material is minimal. That is, it dissolves in 8 to 24 hours. So only for a short duration dressing, if you want to use, you can go for mucoadhesives. However, some surgeons find the short time adequate for protecting the donor and recipient sites of a soft tissue graft of a gingivoplastic procedures. Sometimes you require very short duration to heal. So for them, some scientists and some surgeons feel that mucoadhesive collagen dressings are well enough. Modifications. Many attempts have been made to enhance the properties of dressings as described in the following sections. Dressing along with chlorhexidine. So chlorhexidine, we know, is an established antibacterial agent. In 1989, most commercial periodontal dressings claiming to have initially good antimicrobial activity lost this activity shortly after application. Thus, the addition of chlorhexidine improved their properties as it was proposed. As early as 1975, Addy and Douglas tested the antibacterial properties of chlorhexidine-containing gels in vitro and in vivo, in the form of metaacrylate gels. Chlorhexidine salts were also incorporated into the dressings in the form of powder mixed along with the dressing material. Plus, in 1975, incorporated 15 to 20 milligrams of chlorhexidine dihydrochloride in a periodontal dressing, peripack, which we just saw, and documented a significant reduction in the amount of plaque formation. In another similar study, Othman found that surgical dressings containing antimicrobial agents having high retention and slow release properties are advantageous. In a study by Zeskind, chlorhexidine varnish was used on top of the periodontal dressing. Significantly less plaque deposits were found on teeth having a pre-coated chlorhexidine varnish over the periodontal dressing material, with slow releasing properties also. A review of literature seems to suggest that the addition of chlorhexidine is a valuable asset in post-surgical care. However, since the use of chlorhexidine mouth rinses is preferred by patients, the practice of direct incorporation of chlorhexidine powder in the dressing seems to have waned. Additionally, mouth rinses have a rinsing and washing off effect against the bacteria from the potential infection site and can reach more surfaces compared with any hard or semi-rigid materials. Dressing and the antibacterial agents. So, first was with chlorhexidine, now this is with antibacterial agents. This was to enhance the healing and prevent infections. The earliest reports outlining the use of tetracycline are by Fraley and of zinc bacitracin by Baer et al. You remember Baer et al. In 1969, who said the primary use of dressing should be for patient's comfort and to place the flap in its place. Though the addition of these agents is beneficial, there are a few authors who claim that their addition may be harmful also. Heaney et al. Suggested the removal of dressing within 7 days of application. Two possible problems can occur. First, emergence of resistant bacteria, and second, opportunistic infections. Other medicaments and dressings that have been used. The addition of non-eugenol phenol derivatives like chlorothymol and oil of bergamot was described by Molnar and Sash respectively. This was to improve the post-op healing, and to do that, Saad and Swenson added steroids and dilantin to the dressings. Such agents had been previously reported to increase the rate of healing in skin wounds of rats and humans, but neither agent showed any advantage in these periodontal studies. So you see how much research has been done on periodontal dressing. Whether to use it alone, whether to use it with mixed medicaments, whether to use it with chlorhexidine. So all this only to make sure the healing of the post-surgical wound area is perfectly done. Enough for the patient to comprehend the surgical aspect of periodontics. The substitutes for dressing now. Okay, so enough of dressings. Now we need to see for the substitutes also. So in 1975, the modification of metaacrylic gel for use as a periodontal dressing was attempted. And the results suggested that the modified metaacrylic gel fulfilled the requirements of a periodontal dressing. However, further research has proposed the use of this gel as a dressing material. In 1990, a study was carried out with the aim of evaluating the healing of gingival grafts covered with dental adhesive paste in comparison with the grafts covered with peripack. So there was a comparative study done. One side peripack was placed, other side dental adhesive paste was applied, which is a substitute for the periodontal dressing. The results indicated that the adhesive paste can be used as a periodontal dressing. So it was the 1990 study that supported the use of substitute of periodontal dressing material. Thus, the use of adhesive paste was also considered as a substitute for conventional dressings. Now, the preparation and application. So, how you're going to prepare the periodontal dressing and how you apply it. You need to mold the dressing by pressing at each interproximal surfaces. You apply it, you roll it, and then you apply it on the surgical aspect. Then you start pressing it with a blunt instrument dipped in saline. You need to press it on the interdental aspect. Do not overextend the height of contour of each tooth. You do not have to, press it in such a way that the upper limit of the dressing material should not go beyond the height of contour of that particular tooth. Border mold to prevent displacement by the tongue, cheeks, lips of retina. That means how you do border molding for a CD patient in prosto. You do all the movements. Same ways, but after application of the dressing, you need to do that so that it gets completely adapted. Because obviously, once you leave the patient out of operatory, he's gonna eat food. He's gonna chew like he's supposed to do. So that time the movements will cause a displacement of the dressing. So to not have that adversary, you need to do all the border molding movements. Check the occlusion and remove the areas of contact. You need to check the occlusal surface that there is no remaining periodontal dressing material on the occlusal surface because that is going to hamper once it sets. Inserting the periodontal plaque. A strip of plaque is hooked around the last molar. So you start from the last tooth and it's pressed into place anteriorly. You need to bring it till the anterior aspect. The lingual plaque is joined to the facial strip at the distal surface of the last molar and fitted into place anteriorly. You can go and you can see the images. You can, while I'm reading this line, you can please read look at the pictures, how they have done it. First, they have started with the buccal aspect from the last molar brought to the anterior part. Similar ways, they started in the lingual side and joined distally to the, fitted into the place anteriorly. Gentle pressure on the facial and the lingual surfaces joins the pack interproximally. Then both the side packs have been applied. So what you do is you join both the side packs using a blunt ended instrument, for example, a periodontal probe. You need to dip it in saline and then use it. Otherwise, the pack will come along with the probe. Retention of the pack. Much has been said and thought about the retention of the periodontal dressings. In 1950s, numerous splints and stents were used to stabilize the periodontal dressings. The materials used were acrylic resin, advocated by McKinsey and later by Munz. 1953, Warehog described interproximal use of spiral saws and lengthwise cotton threads. In 52, Kassenfeld mentioned the use of cotton tapes with interdental sutures. Tauman advocated inclusion of wiring to increase the retention. Lot of people said a lot of things. And we must know we are talking about 1940s and 50s. Not much of advancement in the scientific aspect. So whatever available things were there, they were using what? Some people advocated use of strings. Some said interdental wiring to hold the pack in place. Subsequently, in 1970s, Smith reported preliminary trials with polyacrylate dressing materials. Retention of dressing over palatal wounds has always gained extra attention. Through the years, researchers have been trying to search for an explicit way to cover this region and impede the complications that may follow. 92, Ferguson described a technique which utilized a light cured periodontal dressing, that is barricade, in conjunction with surgical exposure of palatally displaced maxillary canines. The procedure was quick and simple to perform. We've seen barricade. Barricade is a part of non-eugenol, dressing material containing no zinc oxide, no eugenol. It's a light cured dressing material. It was noted that a composite intraoral dressing remained secure for days if incorporated with various appliances in the anterior palate, like a quad helix. Now, once the pack has been in place, it's been doing its job. The patient turns up after 7 to 8 days for removal of the pack. What are you going to do? How are you going to remove the pack now? So what are you going to do is insert a scaler or a plastic instrument under the border of the dressing and apply a lateral pressure. Watch for sutures that can get lodged in the dressing. So when you're removing it, when you're lifting it up, make sure you look underneath. See that sutures which are being attached to the periodontal dressings are not getting pulled because otherwise the patient will have pain while even removing the dressing material. Remove fragments of dressing gently with cotton pliers to avoid scratching the thin epithelial covering of the healing tissue. You can even remove the pack in sections if you're not able to take it in toto. You can take it off because it will break when you're removing it. Take some pliers, take some tweezers, and gently lift it and take it off. And making sure that little thin epithelial whitish layer of covering which is on the surgical site is not disturbed. Use a scaler for removal of the fragments adhering to the tooth surface. You can use a scaler or you can use a hand instrument also. Use a curette for particles which are near the gingival surfaces. Syringe with a gentle stream of warm water, or I would say betadine, is enough after you have removed the pack to clear off any debris which might be remaining or which might be clinging to the hard tissue surface. Now we're talking about the physical properties. Two chemically cured and one photo-cured dressing was examined by Fraunhofer. All materials absorbed water. Both Copac and Periocare acted in a similar manner at 23 degrees, but Periocare absorbed far more water at 37 degrees. For Barricade, it was shown that increased light exposure had little effect on its water absorption or solubility. So these are the physical properties. That means what we're trying to say here, what we're trying to state here is that chemically cured Copac or Periocare, they did not absorb much of water. So water could not go in and out of the Copac. So it really prevented the area from any sort of intrusion. The addition of different dressings was also tested. Addition of Copac to a single tooth at 1 hour was about 7 kilograms, but this decreased to about 6.5 at 24 hours and 5 kgs at 7 days. So what are we trying to say? What kilograms are we talking about? Adhesion. Adhesion is always mentioned in kilograms. That is the weight that the dressing is pressuring, applying on the surgical site. So that reduces obviously by 7th or 8th day, and that is when we usually recall the patient so that we can remove the periodontal dressing. Similar ways, addition of Periocare was 2 kgs at 1 hour and 8.5 kgs at 24 hours, but it decreased to 7.5 by 7 days. And so on and so forth, various different dressings have been tested. Watson Combe compared Copac, Peripac, and Peripac improved for their effects on composite filling material and on glass ionomer cement. Placement of adhesive foil between a dressing and a teeth with composite restorations was also tested. And their viscosity was also tested. And none of the dressings exhibited ideal flow properties during manipulation and adaptation. And no dressing exhibited an adequately well-defined set. If we talk about the biological properties, excuse me, just give me a minute. I'm so sorry for the glitch. You need to give me 1 minute. Let me sort it out. There is some internet connectivity error which is coming in. Yeah, now we are back. So we were discussing about the biological properties, effects on wound healing. Eugenol-free dressings were developed to offset the irritant and the toxic properties of liquid eugenol, right? Numerous reports have outlined the adverse tissue effects and intensity of inflammatory reactions with the use of a eugenol-based dressing. At the same time, in vitro studies have revealed that eugenol-based dressings may cause less growth inhibition of permanent cells and primary human leukocytes than some non-eugenol products. It has also been established that dressings like Wonderpack produce greater tissue destruction because they had a lot of eugenol content in them, with more inflammatory cell infiltration and connective tissue response. Comparative evaluation of different non-eugenol dressings have shown conflicting results. Copac in a fewer studies showed a severe tissue reaction as compared with Peripac and Periopatti, which elicited the least inflammatory response, whereas in others, Copac was also seen to cause least damage. So there were conflicting results if we talk about the biological properties of periodontal dressings. Some tests report that eugenol-based dressings caused no tissue reactions, and others reported a severe tissue reaction, and a few reported no difference at all. Thus, differentiating the irritant behavior based on eugenol content cannot be seen to be justified. Light-cured periodontal dressings were not cytotoxic in cell cultures and different cell types. With the development of collagen-based dressings, products like your Cola Coat or Cola Tape had better clinical and histological effects on parietal wound healing than a Copac. The literature thus seems to suggest that in comparison, non-eugenol dressings, what are non-eugenol dressings? Copac, Peripac, right? So the literature says that these dressings are more biocompatible than their eugenol counterparts. Furthermore, dressings falling in other categories including your light cure dressings, barricades, and the collagen-based dressings like Cola Coat. They are better than the conventional non-eugenol based dressings. A lot of studies have been given. I've taken this from a source of an article. You can see the table 6 where you see the studies assessing periodontal dressing cytotoxicity, and they have enlisted some points. The therapeutic effect of antimicrobial agents in dressing. So what is the therapeutic effect? The eugenol-based dressings were found to have a bacteriostatic effect in vitro and were also found to alter the plaque formation, the plaque composition, as a result of selective inhibition. A comparative evaluation of periodontal dressings revealed that the antimicrobial activity of Copac was greatest, while that of Peripac was the least. Again, various studies have given, and I've listed out the various studies which have assessed the antibacterial property of periodontal dressing material. The post-op pain and dressing now. One of the purposes of periodontal dressings is to aid in reducing post-op discomfort. That was the primary feature, if you remember. The primary goal, as stated by Baer in 1969, was patients' comfort. In earlier reports, measuring the degree of pain experienced by patient was done based on the consumption of analgesic tablets. Such studies reported that the experience of pain was significantly more frequent after the use of Peripac than Copac and Wonderpac, based on higher tablet consumption in the Peripac group. We also found Peripac to be having very least antibacterial property also. And now it has proved that the pain perception of the patient also increased after application of Peripac. Also, when sensitivity was observed, it was seen that the highest proportion of sensitive tooth was found to be after the use of Copac and the lowest with Peripac. So sensitivity के मामले में अगर हम देखते हैं in respect of sensitivity, we found Copac to be least than Peripac. Sorry, this has been wrongly stated. Please change it. It is Copac, which is found to be better than Peripac, not Peripac. Pain measurements using visual analog scale, the VA studies, the VAS scale, reported the pain scores with Copac higher than the Wonderpac after a gingivectomy procedure. Obviously, because Wonderpac had more of eugenol content, so it used to necrose the gingiva itself. So there was no pain sensations felt. The same authors in another study compared pain experience after gingivectomy when using a local anesthetic agents. You remember Periogenics, which had a local anesthetic agent. They reported that pain was masked when using a eugenol-based periodontal dressing, thus proving that eugenol dressings cause less pain than non-eugenol ones. Now, the very important part, the very important question, is periodontal dressing is available for all? Is it supposed to be used for all the patients? Now, having discussed a lot about biological properties, the therapeutic benefits of periodontal dressing, the question of whether we need to use a dressing for all the surgical procedure remains open. The fact that complete healing can take place even without a dressing, provided the surgical area is kept clean and that there is no difference in healing between dressed and non-dressed wounds, supports the theory that not all surgical areas needs to be packed. Other factors like presence of inflammation seem to influence the rate of wound healing to a larger extent than the use of a dressing. These are the clinical trials that supports the use of periodontal dressing concept. You can go through that. These are the clinical trials that do not favor the use of periodontal dressings. So basically, you see a lot of study which shows that you do not need to put periodontal dressing. You need to keep the area open, the surgical wound open. You need to just make sure the patient is able to clean that area. The plaque shouldn't be deposited. The food shouldn't accumulate there. But do you think it is possible for the Indian scenario? Because all these authors, all these studies were done in the Western world. For the Indian population, to make them aware, to make them compliant enough to follow the doctor's instructions is very difficult. So I feel personally that the Indian population should be given the periodontal pack, because anyways we have found that periodontal pack is not doing any harm, if not any benefit, at least it's not doing any harm. So there's no problem in putting the periodontal dressing. But still the schools of thought varies. A number of clinical trials have proposed that the use of a dressing accumulates plaque causing inflammation, irritates the healing tissues, produces transient bacteremia during post-op dressing change, and causes more pain and swelling but less sensitivity and difficulty in eating. Despite these drawbacks, it appears that healing is slightly more rapid when it is dressed, when the area or the quadrant is dressed with a pack. The use of periodontal dressing from the patient's preference and comfort point of view has also been elaborated. Conflicting reports exist in the literature as these factors are based on patient responses and thus are not objectively evaluated because of the subjective criteria usually employed. The use of chlorhexidine mouth rinse instead of a dressing has been found to reduce post-op plaque accumulation and surgical inflammation and is considered to be roughly equivalent to the professional plaque control in post-surgical healing. The answer to this controversy now is still open to debate, and is probably that the choice of use of a dressing is a matter of individual preference and the judgment of the clinician. It is, however, the use of dressing for stabilization of the gingival grafts and protection of the donor site, retention of the apically positioned flap, protection of the denuded bone from any further injury, protection of the graft site in periodontal regeneration, and to facilitate retention of drugs delivered locally in the subgingival sites. So, with all, we come to a conclusion, and there appears to be no consensus regarding the absolute indication of periodontal dressing material. However, the literature does elaborate on the benefits of applications of a dressing post-surgically. Moreover, no periodontal dressing material has been shown to exhibit all of the ideal properties, like that is both physical and biologic properties. So there is no such material that exhibits complete 100% all properties. Further research to improve biomaterial properties may lead to a more universal applicability. And as for now, periodontal dressings for all may not be yet answered. You may not have correct answer to it. So with this, we come to the end of the chapter, and I do hope you have understood. You have understood the part now that why periodontal dressings are supposed to be used, where we use it, what are the ideal requisites, what are the different categories of periodontal dressings which is available to us. And I hope you will be able to make a judicious choice whether to use a periodontal dressing after this or not. Moreover, from the exam point of view, I would like to say that this chapter has some importance in short notes and MCQs, and at times this is asked in Viva. As of long notes are concerned, very rarely a question has been put up from periodontal dressing, so you need not worry about it. But you definitely need to study this chapter properly in detail to comprehend and understand the importance of periodontal dressing. So I sign out now, and you can please comment your questions, or if you have any doubt, you can connect with me in the department. Thank you so much.